Greetings, everyone. This is Eric Laser, and welcome to Bright Spots in Healthcare, produced by Shared Purpose Connect. Each episode, we bring leaders together to not only inform our audience, but also unearth bright spots, successes at health plans, hospitals, and other healthcare-related organizations around our country, because our goal is to identify as many bright spots as possible so that you can determine if the ideas shared during this episode can be applied at your organization. We believe that this strategy of finding a bright spot and cloning it is the most effective way of changing healthcare in our lifetime. Our topic today is a super important one. It's rethinking maternity care and equitable access. I was in a conversation a couple of years ago when someone told me that if you are an expectant mother and you're on Medicaid, there's a 10 to 15% chance, depending on where you live in this country, that your baby's going to end up in the NICU. And the NIH examined data for 10 years and found out that the NICU admission rates were highest among Black infants for all those years. In 2020, the HHS Office of Minority Health found that non-Hispanic Blacks have 2.4 times the infant mortality rate as non-Hispanic whites. And according to the Center on Budget and Policy Priorities, the median maternal mortality rate among developed countries is 4.45 out of every 100,000 women. But Black women in the US die at more than twice that rate. These statistics are just unacceptable in our country, and we need to figure out innovative ways to fix that right away. And so our guest today is Dr. Angela Thomas. She is the Vice President of Healthcare Delivery and Research at MedStar Health Research Institute. I want to tell you a little bit about her and give you a little bit of a sense of some of the great expertise you're about to benefit from. Dr. Thomas is responsible for leading a team of experts that apply rigorous scientific methods to enable next generation healthcare delivery through quality, safety, innovation, health economics, payment reform, outcomes, health services research, data science, and last and certainly not least, health equity. Dr. Thomas also ensures that all the activities going on at MedStar and the collective leadership there are combined and collaborated between the folks at MedStar Health and Georgetown University. Her research interests focus on health equity and patient safety. And in March 2020, the A. James and Alice B. Clark Foundation funded $27 million of a $30 million budget for a program that we're going to talk a lot about called Safe Babies, Safe Moms. As the executive leader of that program, Dr. Thomas has overall responsibility for ensuring the development, implementation, and evaluation of this evidence-based program that is reducing disparities in maternal and infant mortalities in Washington, D.C. In addition, she contributes her research expertise in disparities, health equity, and patient safety to all kinds of other journals that get published. Some of the recent articles around disparities in maternal and infant harm that she's published. One was entitled Identifying and Understanding Ways to Address the Impact of Racism on Patient Safety in Healthcare Settings. And the second that was published in Health Affairs, you could Google it, Policy Changes to Address Racial, Ethnic, and Inequities in Patient Safety. So welcome to the show, Angela.
Thank you. I'm so glad to be here, Eric. Thanks so much for having me. I'm excited about this conversation.
I am too. We, the two of us met at a conference a couple months ago in New York. So we've been planning this for a little bit. I'm glad we're able to finally find the time to make this happen. Why don't we start, before we get into sort of bright spots and the program itself, Safe Babies, Safe Moms, and everything and how it works, which we'll get into all of that, folks, because I really want you to understand it and start thinking about how you could take programs you have in your market and apply some of these best practices to what you're doing around helping deliver better outcomes for moms and their children. I want you to tell us a little bit about MedStar, because not everyone knows about MedStar. So let's give us a high level overview of that institution and a little bit of your role in it, and then we'll transition to Safe Babies, Safe Moms.
Sure. MedStar Health is a large healthcare system in the DC, Maryland, Virginia area. We have 10 hospitals and about 300 other locations where we deliver care. We call ourselves the microcosm of US healthcare because we serve some of the richest of the rich and the poorest of the poor. We have community hospitals, urban hospitals, rural hospitals, teaching hospitals. We sit across two different payment systems, fee for service and a global budget system in Maryland. We have a number of what we call diversified entities throughout our system, and one of which is the MedStar Health Research Institute, but some other examples include the MedStar Institute for Innovation, as well as we have our own Medicaid plan as well. So very diverse, sitting right here in the nation's capital, and really excited to represent MedStar Health and the great work we're doing today in this conversation, Eric.
Great. Well, let's get to it. Tell us a little bit about what Safe Babies, Safe Moms is. I gave a little bit of a tease in the intro, but let's give our listeners a little bit more color on to what the program's all about. And then I'll get into we'll get into the weeds a little bit.
Sure, you did a great job teeing it up. I'll just say that DC, some of those numbers that you quoted in terms of statistics for maternal health and infant health, DC has some of the most troubling statistics in our nation. And so it was really important for MedStar Health to come to the table with funding from the A. James and Alice B. Clark Foundation to tackle adverse maternal and infant health outcomes in the district. And so that is what Safe Baby, Safe Moms is targeted to do over 5 years. And it's a multi-generational integrated care delivery approach with not just us at MedStar Health, but also with community partners, Community of Hope, which is an FQHC in DC, and Mama Toto Village, which provides wraparound services for birthing individuals of color in the district. And so together, we form a team that is aiming to tackle these adverse maternal and infant health outcomes with a specific emphasis on those disparities that you called out.
When you were able to get that grant awarded to you, was that a 3-organization partnership that went in to compete for it and to earn it, or did you guys earn it and then you brought in those CBOs?
It was a conversation that MedStar Health initiated with A. James and Alice B. Clark Foundation. And as we began to mature the idea, we began to bring in those those community partners, because we understood that was necessary. And another thing we did in those conversations was bring in the MedStar Health Research Institute to create a research arm that went alongside the clinical initiative.
Perfect segue. Let's talk then at a high level. What is Safe Babies, Safe Moms, and what is that Research Institute's role in the overall program?
You got it. So we bring together 4 of our clinical service lines here at MedStar Health. That's women and infant services, think obstetrics and midwifery care. It's also family medicine, community pediatrics, and child and adolescent psychiatry. And then, as I mentioned, we have the 2 community partners, Community of Hope and Mama Toto Village. And we really look at the initiative at 5 key stages. So there's preconception, prenatal, delivery, immediate postpartum, and then 0 to 3 years of age for the child. And across each of those 5 time points, we are screening and referring and addressing social determinants of health, as well as behavioral health needs. And then we're also providing care navigation support throughout all 5. Within each of the 5, we're identifying individuals who are at high risk for adverse maternal or infant health outcomes. So for example, in the preconception space, if there is a woman who has uncontrollable diabetes or uncontrollable hypertension, we want to address that, because if she does become pregnant, that can turn into gestational hypertension or diabetes. For example, prenatal. In the prenatal space, of course, we want to do prenatal care, but we'd also do things like breastfeeding education and begin to make sure that pregnant individuals are linking to pediatricians. Those are just a couple of examples. We also have clinical care bundles for all types of clinical indicators.
Okay, let me do I want to do a quick little summary there. Before I summarize the 5 stages, you mentioned key clinical components to the program that I didn't get. And I want to make sure that listeners hear one more time. You mentioned psychiatry, and there was 1 or 2 more that preceded.
Yeah, sure. So women and infant services, that's obstetrics and midwifery. and then child and adolescent psychiatry that you just mentioned, family medicine, and community pediatrics. Those are our key clinical service lines.
Okay, so women and infant services, child and adolescent psychiatry, family medicine, and community services.
Community pediatrics.
Community pediatrics. Jeez, my bad. I'm taking a few notes as well.
No worries.
5 stages: preconception, prenatal, delivery,
Immediate postpartum, and then 0 to 3 years of age.
okay, immediate postpartum, and then 0 to 3 years in age. For some reason, I thought it was 3 to 5. So 0 to 3 years.
Mhm.
Perfect. All right. So let's talk a little bit about the stages and some of the key components to the stages that make this program different and effective in accomplishing its goals. Actually, let's back up. What are the goals of the program?
So our goals, we focus on a few different clinical outcomes. So we measure success by looking at how our birthing individuals in infants fare in a number of ways. So a couple of them: severe maternal morbidity. We look at low birth weight, both less than 1,500 grams and less than 2,500 grams. We look at postpartum readmission rates. We look at preterm birth rates, so anything less than 37 weeks gestation. I think those are our major outcomes. In addition to those, we judge our delivery of care by about 50 what we call process metrics. So these are things that we hold ourselves accountable to do 100% of the time. So for example, screening every pregnant person who comes in for social determinants of health needs and behavioral health needs. We can screen and refer 100% of the time. And so we have 50 of those throughout all of these different 5 stages that we hold ourselves accountable to.
Severe maternal mortality rates, birth rates in general, postpartum readmission, preterm birth rates, and then within delivery of care, you have like a bunch of HEDIS-like process metrics, a bunch of them that we're not going to cover all here, that you also have in that delivery of care, which is critical.
You got it. Severe maternal morbidity is what we look at. And then there is another one, our nulliparous cesarean rates. So this is the pregnant person's first pregnancy, and whether or not that first pregnancy turned out to have a cesarean or not.
Okay, so getting to the stages now and how this all works. So tell us a little bit about how the program works, but with the lens on where are some of the areas that you think are maybe largely overlooked when you're building a program like this in another market that you've seen is super important. For example, you mentioned obviously pediatrics and making sure that the person has an OB, but there's also, right, thinking about does the member have a lawyer in certain cases. So could you talk a little bit about some of the key things that are often overlooked in a program like this so we could double down on those?
Sure. I'll start with the research arm. So one is often overlooked is the need to evaluate what's working, under what conditions, is the intervention effective, and what are the costs associated with that? So we bring our MedStar Health Research Institute to the table: implementation scientists, health equity researchers, data scientists, informaticists, health economists, and more come around the initiative to really be able to, for us to be able to measure whether or not we're making a difference. So that's one thing I think often gets overlooked in an initiative like this. From a clinical care perspective, I think the integration of those different clinical service lines is often overlooked, because each of them independently are touching these families, but the power of bringing them together is bringing those lenses together, because the family is a family. You don't parse out the family, and we're not pieces of individuals. And so if we can have pediatricians working with psychiatrists, working with family medicine, working with the midwives and or the obstetrician, it's more of a holistic approach to ensuring proper care for not just the mother or the birthing individual, not just the child, but the entire family.
So, and when you have this integrated program, it's all often something that your members, do you call them members, patients, consumers? How should I be?
We got patients and families.
Patients and the family aren't necessarily familiar with what an integrated clinical care experience looks and feels like. So how do you make sure that they're taking advantage of that and they're getting their appointments made, and how does just overall coordination care navigation work?
Yeah. So when we designed the initiative, we had really intentional conversation about what enrolling in Safe Baby, Safe Moms, finger quotes, really means. And we decided that it would just simply be the care delivery model. So we've designed it such that the patients and families don't have to necessarily worry about taking advantage of Safe Baby, Safe Moms. When they interface with our providers, we hold ourselves accountable to screening for all the things that we said we screen for, like social determinants of health and behavioral health needs and health harming legal needs, which we'll talk about a little bit. We hold ourselves accountable for the care navigation and following up with patients and families. We hold ourselves accountable for making sure that we screen for the clinical indicators that are necessary and provide those care bundles that go with that. And so when the patients arrive, they don't have to be responsible for, oh, will you give me that social determinant of health screener? Because we just simply provide it. And so that helps with access, that helps with ease in a very life-changing circumstance.
Okay, I want to summarize what we have so far for our listeners, because this has been a lot here. So far, I'm hearing maybe three, I dare say four core components. They're not necessarily individually unique, but maybe bringing them all together into a program like this is unique. First is the research. So making sure that you have an arm, a team of data scientists who are looking at what's working, how is it effective, and what are the costs associated with it at a high level. So you need to be always looking at each particular component of the program with that kind of lens on it. The second is you're putting forth and presenting an integrated clinical care program. So it would be number two, to have that in place. The third, which I'm sure a lot of organizations listening are doing, is you're screening for social drivers as well as clinical indicators to help shape that care plan for the individual patient. So now we have those things in place. You also mentioned a couple of times, and I alluded to it in the question, you're taking ownership over care navigation. So could you tell us a little bit? So care navigation, we all know what that is. In principle, it's simple, but when we're talking about traditionally underserved populations, there is a challenge in getting someone to pick up the phone and, I dare say, trust you with navigating you through care. So how are you grappling with that in Washington, D.C.?
Sure. There are a number of different approaches that we choose to use, and they can vary by our different clinical areas. For example, in the community pediatric space, there is one individual who knows every single person by name, who there's usually this longitudinal relationship that she's established with families. And so she doesn't tire of calling, texting, but also asking how the person is doing, seeing the person. So establishing that trust factor in the process so that she can make these connections.
Is she a nurse, just a coach, a CHW? Like, who is this woman that's...
Social worker is her training.
So she's a social worker, and she deals with all the pediatrics and ensures a longitudinal relationship.
Yes, yes. And she has built relationships within the community for places where those patients and families need to be referred to. And so that works. In other spaces, we leverage community health workers, those who have lived experiences coming directly from the community. So the trust is established because there's a relationship of lived experience in the very communities from which the patients come from. So that's helpful. There also is Mama Toto Village, who they have lived experience as well, and they wrap around the entire the entire patient and family. And so home visits, relatability, trust, all of those things are kind of baked in to the approaches that we have.
You say that organization one more time?
Mama Toto Village, that's one of our community partners.
And they're obviously just in Washington, D.C.
Yes.
And what about how do doulas play a role in navigation or in just building trust, or are they just there for that more, I guess it's not acute because they're there prior to the birth, but what are their roles?
So for Safe Baby Safe Moms, we don't specifically have a doula arm within Safe Baby Safe Moms. However, we do welcome doulas and doula care and value the role that doulas play. In the literature, doulas have a high efficacy in being able to help move the needle in maternal outcomes when the patient is allowed to choose who that doula is. And so we've seen in our study that when we have a consistent person, like a doula is a consistent person, but a consistent person like a care navigator or a social worker or a perinatal navigator or a community health worker, having that trusted person that walks hand in hand with them throughout that perinatal journey is also very, very effective. So it's a consistency of presence that we're finding for our patients that's making a difference.
Okay, I want to go back now to some of the non-clinical drivers of good or subpar kind of outcomes here and how you're potentially addressing those in a way that maybe people aren't thinking through. So obviously, when we think of social determinants, shelter is the first one, right? But what we often, at least on the interviews I have, we look at shelter as pretty binary. You either have a home or you don't, and how do you deal with individuals in both of those domains? But in fact, there's probably different levels of drivers within those categories. So if you do have a home and an apartment, there are often things about that environment that are not necessarily healthy, and how to identify those and how you help your patients manage those. Can you talk a little bit about that?
Sure. So one of the bright spots in Safe Baby Safe Moms is that we do have what we call the P-Law Project or the Perinatal Law Project. And it's a medical legal partnership that's embedded right in the clinic of our Women and Infant Services location. And so what happens there is that we screen patients for what we call health harming legal needs. We also have the same team embedded with our community pediatrics team. So they're also screening for health harming legal needs. And what those are true legal issues that are affecting the health. And so an example, since you brought up housing, an example could be mold that's unaddressed by a landlord in an apartment or a house that is causing the child exaggerating asthma. And so that child continues to go to the emergency department because they're coming back where there's unaddressed mold. So what this team does is that they have a lawyer that works directly with that family to have that issue fixed with that landlord. So they'll write legal letters or represent them legally, so that landlord has to address that mold issue. And when that landlord addresses the mold issue, so legal issue is fixed, then the health becomes better.
Love that. Love that. Is there any other areas that maybe the traditional healthcare leader wouldn't be thinking of? Like that's pretty niche-y that I've never heard addressed during my interviews, and I've had a lot of really incredible people on the show. So are there things about in the program that we haven't touched upon yet that maybe folks aren't necessarily thinking about that allow this program to be successful?
Sure. We have several pockets of innovation, pushing just a little bit more on the health harming legal needs. So that expanding that to income support, paid leave, back wages, health insurance coverage, debt relief, rent abatements, security deposit refunds. We've done a lot of that work, amounting to more than $200,000 we've been able to recover for our patients to date. And another way we're leveraging technology is using artificial intelligence, natural language processing, and clinical informatics techniques. And how we're doing that is that we're able to look at our electronic health record and identify these signals in the electronic health record that tells us who is at high risk for adverse maternal outcomes. For example, we have found that Black women are at highest risk for anemia in pregnancy. But on the other end, we've also determined that they are less likely to receive the care that they need for that anemia in pregnancy. So using these techniques, we're going to continue to identify, but also make sure they receive the care that they need. The other thing that go ahead, Eric.
Are you using a third party to help you with that? Are you developing that AI in-house? How are you executing on that?
It's in-house, and that again is another reason why having a research organization alongside this initiative has been so beneficial for us. So it's our data scientists and our clinical informaticists who have done the amazing work to figure these pieces out for us. And so in addition to those, they've used natural language processing to analyze the clinic notes that providers put in the electronic health records for things like negative tone and sentiment, which could be indicative of bias in care. And so we have found that not just in the maternal space, but in other spaces, that Black patients and Black women are more likely to have negative tone and sentiment revealed in their electronic health record, which could be indicative of bias. And so what we've done is kind of take what we found from these research ideas and taking it to the next step out of Safe Baby, Safe Moms. We have an amazing opportunity through the Clinton Global Initiative to have a commitment to action where we're developing a surveillance, sort of not real time, but more upstream surveillance to identify patients at highest risk for adverse outcomes, B, make sure that they receive the care that they need, and C, make sure we're delivering that care in a non-biased, non-discriminatory way. So it's designed to be this feedback loop to clinicians, to operational leaders, et cetera, to ensure that we're doing exactly what we need to be doing to deliver that care in an equitable way. So one of the things I talked about a little bit earlier was importance of linking pregnant people to pediatricians while they're still pregnant. And so a chatbot we've been able to activate to check in on the status of that. Have you done that? And if you have not done that, here are a list of pediatricians that you can link to, checking in to make sure that happens, et cetera. We also leverage chatbots for warning signs, both at the the newborn side, as well as the postpartum side. And so these come from understanding in the literature the importance of pediatric linkages to care, but also knowing early warning signs, because we know that, especially in the postpartum space, that first 42 days is the most dangerous period for Black women specifically. And so being able to figure out how to supplement a 6-week visit a little bit too late and backing that up with technology, but we also back that up with a 2-week visit in our program. So I think people miss, especially when it comes to the dangers of Black women in the postpartum maternal space, they miss that critical period of what they now call that 4th trimester, the 42 days postpartum, missing interventions right there and missing supports right there to help mitigate issues there. So those are just a couple of examples I can come up with, Eric.
No, I love that. How do you look at the program as it relates to your patient population and who comes into the program? Are there different sort of, I'm using this term, I know you didn't, but like pathways you put them on, and like how do you take the entire population and make sure that you're not just giving a one fit for all kind of approach, because that's not going to work. So how do you think about your patient populations, and how do you bring them into the program in different paths?
Sure. So in each of those 5 stages, we can have people who come in at preconception, and then we can have people who we only see at delivery. Then we can have people we only see at the pediatric 0 to 3 years. So we've landed at the space where if you see a provider in Safe Baby, Safe Moms, you're automatically a Safe Baby, Safe Moms patient or family. And we leverage those processes that we put in place, like the screenings, to make sure we're doing those, and then that dictates the pathway that the patient and family then follows from there. So clinically, if their blood work comes back where there's gestational diabetes or gestational hypertension, that pathway that goes into the care bundle pathway. If they screen for a health harming legal need, they go into the medical legal partnership pathway. And as you can imagine, patients can have multiple pathways they end up going in, and some can have not many at all. They leverage because they're not high risk for many things. And so that's how we manage it is our processes, is that we make sure we follow those processes, and those processes tell us what the next step for each of those patients are.
Okay, so if I'm gonna bring you, and this is maybe I'm gonna give you a little bit of a live test here. Let's bring you into another market. It could be any market, but let's bring you into sort of, I don't know, I'll say St. Louis, and you are being asked to build a similar program in St. Louis now, and you're under the umbrella of a research institute there. So I don't know all of the hospitals there, but I'll actually make it Salt Lake City. We'll go there and we'll call it Intermountain. But your budget's limited. So in this case, it looks like, if my math's right, you're running on a $5 million a year budget, right, or $6 million a year budget, right, roughly.
Mm-hmm. Yep, roughly.
We could cut that in half.
Mm-hmm.
And now you have to start something in year one. What are like 2 or 3 things you would advise your colleagues at Intermountain to start with? Maybe they don't have all the resources you do, but how do we get this program started so we can start making a meaningful impact for the community?
So the first couple of things I would recommend is getting together that interdisciplinary team. So that would be staff in-house. So bringing together in a structured way, whether that's regular meetings, whether that's a formal conversation, a retreat, some kind of structured way. The obstetricians, midwives, pediatricians, family medicine physicians, psychiatry or behavioral health professionals, and then also identifying trusted community partners as well to bring to the table. And first start having a conversation to uncover what are the things that those particular experts are seeing clinically and in the community as issues. What are issues in DC may not be issues in Salt Lake. So we want to make sure that you identify those things that are relevant. Then you mentioned Intermountain Healthcare. They have a really robust research team and quality data analytics team. So I would recommend they gut check that with the data that they have and run some of the analysis. The data actually reflect what the clinicians and community partners are saying are issues. There also could be community health needs assessments that are already done that they could leverage as well. But then from there, it should generate an opportunity to see where gaps are and where opportunities to address things are. And from there, I would recommend picking a few areas. A couple of areas that seemed to be really consistent for us is the screening and referring and addressing for social determinants of health, behavioral health needs, and having some kind of care navigation, whether that's coming from the mental health side, a social worker, a community health worker, but some kind of consistent person that comes alongside that patient and family throughout that perinatal journey to help them access, to help them navigate, to help them with questions they may have. I think starting there can be very powerful. Having the conversation, engaging the community, bringing minds together, identifying the gaps, and then finding 1 or 2 things that you can tackle, but try to at least put those components in place.
Okay, in summary, this is what I heard. Build an interdisciplinary team. You mentioned as part of that team, and I think this is important. Uh, the OB, you mentioned family doctor, pediatrician, mental health professionals, midwives, and trusted community partners.
Yes.
If you have the capability, go in, review your data and the community health needs assessments you may have already executed on, and take a look at the most significant gaps. And then before we build interventions to address those gaps, I'm going to actually pause that one. And actually, you mentioned make sure you're doing SEOH screening and have a strong care navigation team, even if it's small, but strong in place. And then build interventions to address those gaps that you identified. That would be sort of the blueprint for those who are trying to start a program, maybe with not as much funding that you have, but can make a big difference on all kinds of business metrics, not to mention the altruistic part of this as well.
Mhm. I would, and just want to make sure you heard the behavioral health screening as well, the mental health screening. That's important.
So where could folks learn more about this program? You know, where can they learn more about Safe Babies, Safe Moms? And if they needed to reach out in a non-invasive way, how do they learn more about Angela Thomas and connect with you?
Sure. For Safe Babies, Safe Moms, they can go to medstarhealth.org/Safe Babies, Safe Moms. All of our information is there. There, you can also find a space to reach out to me. There's an email address for Safe Babies, Safe Moms. I think it's as simple as safebabiesafemoms@medstar.net. But also, you can find me, Dr. Angela D. Thomas, on all social media platforms. That's pretty easy to remember. Angela D. Thomas, Dr. Angela D. Thomas. And I'm also available via email. I don't mind. Angela.d.thomas@medstar.net.
Oh, that is pretty generous. We'll put the email in there, but we'll put your social media handles and some of the other suggestions you made into the show notes or into the description of the show, so people who are listening could just click on their podcast app and access it that way. So Dr. Angela Thomas, thank you so much for all the time you took with me to prepare and for the time you took today to speak with all of us. My message to everyone listening is use this strategy of looking for bright spots, things that are working well among the chaos. Take these tactics that generate progress, whether it be a small piece of Safe Babies, Safe Moms, which is this complex integrated research-based clinical care program that you could take components of it and bring it to your organization. This is why we do the show. We hope to inspire your thinking and enhance your company's current approach to improving healthcare for all consumers. This is your Bright Spots in Healthcare podcast. Take care, everyone.